You hear my voice? Okay. Today we're going to have webinar on intervention that we can do in a patient who have pulmonary TB. So for today's webinar, we're going to have Dr. Arvindran from Sultanah Bahiyah Hospital. He's going to talk about airway stenosis, followed by Dr. Taufiq from Queen Elizabeth Kota, Kinabalu. His topic is on pneumothorax and bronchial-pleural fistula, followed by Prof. Faisal from UKM, talking about Empyema Thoracis. And the final session will be Prof. Adli, our cardiothoracic surgeon from UITM, is going to talk about indication for surgical intervention. For each topic, the presenter going to present for 30 minutes, followed by 10-minute question and answer session. If you have any question, you can put that question in the chat box. I'm going to read the question to the presenter. For during each end of each presentation, I'm going to project the QR code for the CPD point. CPD point for today's webinar will be 2 points. Hopefully, after 2 weeks of the event, I'm going to forward you with all the recorded video and the PowerPoint of the presenter. I would like to invite Dr. Arvindran to share his presentations. Dr. Arvindran, the floor is yours.
Okay, thank you very much, Dr. Amin and UITM for inviting me and also collaborating with Chess Alor for this wonderful topic. So allow me to share my slide first. Okay, I think, can you all see my slide? Okay, so am I audible, Amin?
Yes, Arvin.
Okay, so you can see my slide, right?
Yes.
Okay, great. Okay, so thank you very much, Amin, again, for the wonderful session for the intervention in tuberculosis. I think many of us know that tuberculosis is very rampant in our country, but again, somehow the intervention in tuberculosis always being outlooked because of the infective nature of the disease per se. And then, endobronchial tuberculosis are not easy to pick up as we are more heavily dependent on a sputum ARV per se. So here, my topic, I'm going to talk about endobronchial tuberculosis. How do I intervene? So this is a Hospital Sultanah Bahiyah from North Malaysia, and this is where our iconic landmarks of Menara Al-Sultan, and we have Langkawi, and this is where we're situated. Okay, so I'll start with the case study first. A 60-year-old male presented with prolonged cough and dyspnea. Image to be shown in the next slide. BL sputum AB, 3+, gene expert, MTB detected, however, no rifampicin resistance detected. He was commenced on a conventional tuberculosis for 6 months duration. So post-treatment, he went to the private center and patient still having a dyspnea, and they subsequently proceed with the flexible bronchoscope at the same time CT scan. If you notice here, there's a critical narrowing when we measured, it's around less than 2 mm actually. So with that, I would like to go with the outline of my topic, which is I'll talk about endobronchial tuberculosis in general. How do I intervene endobronchial tuberculosis, interventional pulmonology methods, and flexible bronchoscopic intervention, because this is close to my heart, and a bit of our protocol in Al-Sultan, and also conclusion. Okay, so endobronchial tuberculosis, if you notice, it's a tuberculosis infection involving the tracheobronchial tree with histopathological and microbial evidence. And it should have a presence of visible endobronchial lesion proximal to segmental bronchi. And again, pathogenesis of endobronchial tuberculosis is not fully established, but again, most commonest pathogenesis which we postulate is direct implantation of tubercle bacilli into the bronchus from adjacent pulmonary parenchymal lesion, or airway infiltration from the adjacent tuberculous mediastinal lymph node, or intrathoracic lymph node. So these are the few postulated theory actually. Again, other potential mechanism or theory are implantation of organism from the infected sputum, hematogenous dissemination, and lymphatic drainage. Various literature talk about the various percentage of the patients with active tuberculosis, which manifests as endobronchial tuberculosis. Certain literatures is go as low as 10%, but majority is around 30 to 40% actually. and more common in the pediatric population and young adults, especially young females, middle age group, around 35 or 40. Okay. So this is a study done in Korea actually. So if you notice, concomitant endobronchial tuberculosis can see in 54.3% of the total active pulmonary tuberculosis patient. And if you notice, endobronchial tuberculosis located within the lobar bronchi constitute around 199 cases, and confined to segmental bronchi only around 34 cases actually. So looking at this particular data, actually if you notice the endobronchial tuberculosis, actually the incidence is much more higher, or can be higher than what we predicted in our local setting. And this is the female sarcoma, common in females, and it's located within the lobar bronchi, almost at 50%. And based on the subtypes, actively cavitating is majority. And if you notice, central airways involved commonly around 85%, and trachea around 16%, whereas main bronchi and lobar bronchi is the majority of the place where it get involved actually. And if you notice, usually a grade 1 stenosis and grade 2, grade 3 are subsequently followed by the grade 1 stenosis, the rate of it actually. So we need to know about the classification. So based on the Chung et al. Method, it classified into 7 subtypes. Actually, most of us follow this particular classification. And if patient have 2 or more subtypes, we classify in according to the dominant form. And also you can classify by the number of involved levels. So single level endobronchial tuberculosis, or if this is defined when it's only involved one side of the airway, either should be either trachea, one of the main bronchus, or lobar bronchus. If let's say it's involved more than 2 sides or more bronchial levels, defined as a multiple level endobronchial tuberculosis, like if you notice one main bronchus and one lobar bronchus, or trachea and lobar bronchus together, and usually it should be occur proximal to the lobar bronchi. It's like we call as a central endobronchial tuberculosis. So this is a broadly classified as how we classify it based on the number of involved level, and the forms, the stenosis we grade it as the grade 1. I think all of us know turbinal narrowing less than 1/3. It's more than 1/3 and 2/3 is involved as a grade 2. More than 2/3 involvement of the stenosis level as a grade 3 stenosis. So these are the pictures from the Chung et al. Publication, which is published in 2000, I think, the year of 2000. So it probably classified into 7. If you notice, actively cavitating endobronchial tuberculosis defined as swollen, hyperemic, diffusely covered with white cheese-like material. Invariably, this will be accompanied by luminal narrowing at the diagnosis. Edematous hyperemic endobronchial tuberculosis is the lumen is always narrowed due to the severe mucosal swelling with surrounding hyperemia. Fibrostenotic endobronchial tuberculosis shows a marked narrowing of the bronchial lumen with fibrosis. And tumorous endobronchial tuberculosis, like the endobronchial mass, will be present and commonly mistaken for the malignancy per se. Granular endobronchial tuberculosis is like a grain of boiled rice. Ulcerative will have a bronchial ulcer, and non-specific bronchitis is a mild mucosal swelling or hyperemia. So here's some of the endobronchial tuberculosis seen in our setting. So this is the actively cavitating 18-year-old female with a prolonged cough. If you notice, 60-year-old female with loss of weight and prolonged cough, initially we thought it's going to be the malignancy, then ended up as a tumorous type of endobronchial tuberculosis. Middle-aged gentleman presented with hemoptysis, granular type. And this is a non-specific, actually, if you notice. Just I'm highlighting this because the patient having the thick bronchus on this particular patients, as evidenced by our CT scan as well. So literature says that it's more common in females, and normally symptoms present more than 4 weeks. In certain literature, one of the predictors for endobronchial tuberculosis being mentioned as the symptoms before present to our healthcare facilities more than 90 days. But usually, majority of the literature mention symptoms last more than 4 weeks and common in females. Why females? Because of either cultural background. Females are less expectorate the sputum containing bacilli due to social, cultural, and aesthetic factors. And structural per se is because structural difference in female bronchi are narrower than those of the females actually. So later I will mention in anatomy about the differences in the airway sizes between male and female. And most of the endobronchial tuberculosis if you notice, will respond to standard anti-tuberculosis medication. And usual diagnosis via bronchial-pleural lavage or washing or HPE per se. Usage of oral steroids is a controversial again, but this systemic review and meta-analysis shows that this does not help with patients with endobronchial tuberculosis. But again, it depends on the center's practice and individual physician choice. I'm sure quite a number of us do give oral steroids for the endobronchial tuberculosis, but in Alor, we don't really practice oral steroids. And most important, interventional pulmonary plays a crucial role in diagnosis and managing the endobronchial tuberculosis. Includes a diagnosis, we have to rule out other pathologies like malignancy, and management of complications, which we're going to talk about the airway stenosis later. So what about the local data? So if you notice, this local data published by UiTM per se. So bronchoscopy features morphology and endobronchial tuberculosis in the Malaysian tertiary hospital experience. If you notice, it correlates with what Korean data and other literatures. Female are predominantly affected, middle age group, and actively cagating endobronchial subtype is common in Malaysian setting as well. So if you notice, our data correlate with the international journals or findings as well. So back to our case. So what we have done is actually this patient referred to us from the private center during the peak of COVID season, where Alor was hit badly with the second or third COVID wave, where our ICU overwhelmed. We don't have an OT slot. We are practically changing every single available space into the COVID ward or COVID isolation place. So, but patient having symptoms. So what we're going to do? So we tried something novel at that point of time. We tried to open up the stenosis under conscious sedation, and to our surprise, post-procedure, the LMB patency was achieved and distal segment bronchi visualized in a single setting per se. So if you notice, this is the pre-procedure, and this is the post-procedure on this within the same setting itself. So if you notice, you can start visualize the airway lumen is definitely bigger than compared to the beginning of the procedure, if you notice. And based on the Henry Cole journal, if you notice, flexible bronchoscopic balloon dilatation for non-malignant airway fractures is feasible under experienced bronchoscopies. And whether it's going to be sustained for a long time or not. So we did a CT scan 3 months post-procedure showing the left main bronchus measuring around 5 mm. If you notice, previously less than 2 mm, critical narrowing, and now it's patency at the 5 mm. Again, we did a follow-up CT scan at the 8 months, and it's patent at a 6 mm. If you can see that visual is clearly can be visualized here. The patency is around 6 mm. And if you notice, it is 6 mm is sufficient. If you notice, LMB diameter is around 7 to 10 mm. So 6 mm is, we are talking about around 60 to 80% of the diameter, which is sufficient for the patient to be asymptomatic at all. And this patient, after our procedure, he back to his work as a farmer. He having a farm. He's staying around easily around 1.5 hours away from Alor. And he's able to get back to his work. He's very well as of now. And in this particular case, he has been symptom-free for almost 19 months from our first intervention, and he did not require any further intervention following our first attempt. So this gives us a bit of motivation and also urge. Why don't we start using this method in other patients who are presenting to us actually? Because not every centers are equipped with the rigid bronchoscope. And let's say this particular method is being useful in treating our patients, why can't we liberalize this method to every other center? So that's our aim. So again, how about the lung function test? Pre-procedure, if you notice, FE1 2.25 liter, 6 FEC is 3.25 liter, 79%. 6 months post-procedure, 2.37 liter. Actually, static, or I would say, is improved a bit. FEC is a static. So again, this lung function test is doing significantly improved, or I would say even static. So how do I intervene? So if let's say tracheal stenosis, definitely we have to go through a rigid bronchoscope, electrosurgical knife, or balloon dilatation. So these are the combination of the electrosurgical method as well as a rigid bronchoscope, because we need to share the airway with our anesthesiologist actually. But right main bronchus and left main bronchus stenosis, whether we can use flexible bronchoscope, is it a new ray of hope? So based on our particular experience in our center, I think this is definitely a feasible method. So when to intervene? So life-threatening, definitely we have to go in immediately. If other patients, normally I would say at least 14 days of antituberculosis or at least sputum converted means became a negative, then we can go in because we want to reduce the spread of TB to healthcare workers. So why flexible bronchoscope? Again, flexible bronchoscopic balloon dilatation is simple. It's minimally invasive method because we are not going to put the patient on a GA. We are not going to use a rigid bronchoscope. Immediate symptom relief as this patient will be discharged the next day itself and patient able to ambulate. Does not increase the stenosis of the length, stenosis length after the dilatation per se. But we have to keep in mind that balloon dilatation itself may cause a secondary airway injury. The over-dilated, we can end up tearing the airway, and patient can even straight away deteriorate under the table. Overgrowth of granulation tissue during airway repair may cause a restenosis. Over-dilation may cause airway laceration, as I mentioned earlier, and hemorrhage. So if we are not well trained, airway laceration and hemorrhage can be a very, emergency and a very panicking situation for many of us. So we have to be extremely careful in choosing the right candidates as well as a proper setting to do these particular cases. So again, how are we going to start with this kind of procedure? First of all, I would like to say that we have to analyze the scene. So we have to know where exactly we're going to dilate, how much we plan to dilate, compare if let's say it's involved the left main bronchus, I would say we have to compare the right main bronchus. What is the average diameter of the right main bronchus or normal bronchus, and know your airway anatomy well. So if you notice, we have to know that trachea are usually around 100 mm long and it's around 15 to 20 mm in diameter. So we have to know that very well. So right main bronchus around 2.5 centimeter long and around 7 to 10 mm in diameter. And if you notice, right bronchus intermediate around 2 centimeter in length. So you have to remember this by heart. And right main bronchus usually wider, shorter, and also more vertical actually. And left main bronchus slightly curved and longer, around 4 centimeter, and diameter is almost 7 to 10 mm. So this will help us to estimate our dilatation as well as how much we want to dilate. And second, we have to train our staff for resuscitation. Although it's relatively safe, but we have to stand by for every possible complication which may occur. Patient can go into, airway laceration, and patient can go into, CO2 retention if let's say patient having COPD. So we need to stand by our emergency trolley. Usually I'll place a emergency trolley with a ETT size 7.5 or 8 mm standby. And also I'll stand by my NIV on the same setting for this kind of patient. And we need to make sure our CRE balloon functioning very well. So this is the most important basic thing before we even start doing the procedure actually. Okay. So as I mentioned, this is the airway. So right main bronchus, left main bronchus, bronchus intermediate. So, and it's around 10 centimeter long, 2.5 centimeter, 2 centimeter, and 4 centimeter long. Okay, so this is roughly we need to know by heart. So how are we going to perform in our center? Usually will be inpatient procedure where I bill 1 day before after routine blood investigation. Usually I prefer to have a latest chest x-ray and also ABG on admission. Patient will be fasted overnight. I prefer to give a IV hydrocortisone 200 mg stat and net combinant prior to procedure. So just to make sure that there's no bronchoconstriction or bronchospasm during the procedure. So this is a part of ACE protocol. ACE protocol is a pre-procedure. And during procedure, this is the first thing my MA will identify the CRE pro-wire guided balloon. Pro-wire guided balloon. So normally we use the Boston Scientific balloon here. So usually I prefer to use a 6, 7, 8 mm balloon, so that's sufficient because you notice right main bronchus or left main bronchus, we are talking about 7 to 10 mm in diameter. So 6 to 8 mm is sufficient for us to achieve the 80% of the diameter here. So make sure it's functioning well, fill it up with the water, and it's functioning well. And then usually we have to use the therapeutic bronchoscope. So after we intubate the flexible bronchoscope, identify the place, and we insert through the working channel. And then once we identify the place as seen here, remove the guide wire and then inflate it based on the ATM. So how much you want to dilate it. So usually I'll go with 3, 4, or 5 ATM, which is either as indicated by 6 mm and 7 mm, 8 mm. So usually we dilate for 2 minutes, withdraw the balloon, observe for surroundings, and then we go in, inflate again for another 2 minutes. So usually I'll try to do at least 2 to 3 times with the various diameters until be able to pass through the therapeutic bronchoscope without any resistance. So if you're able to pass through your therapeutic bronchoscope without any resistance, I mean, it's supposed to be around 7 mm diameter because your therapeutic bronchoscope is 6.0 mm diameter. So you should be able to pass through the stenosis, mean you already achieved the 7 mm minimum. So it's sufficient, and I think then we call the procedure. So if you notice, this is the one of the pre-procedure lumen. If you notice, almost a pinpoint and barely visible any lumen here. And post, if you notice, able to open up, definitely it's wider, and we can able to put our scope and see the distal segment. So this is how we measured our success of the procedure. So again, post-procedure, definitely you have to observe in the ward. Chest X-ray needed post-procedure to make sure we are not missing any airway laceration. And usually I prefer to give IV hydrocortisone 100 mg/TDS for 1 day, so just to prevent any bronchospasm, and discharge the next day with prednisolone 30 mg OD for another 5 days. Again, if you ask me, do we have any randomized study for this particular protocol? Definitely no, because I try to devise this particular protocol based on the idea that the patient shouldn't develop bronchospasm immediately. So, and all our patients we use this particular protocol noted they didn't suffer any bronchospasm during the procedure as well as the post-procedure immediately. And I'll repeat the surveillance bronchoscope in 6 times. So this is our experience. If you notice, again, ours are females. So patency up to an 8 mm, 7 mm, and 6 mm achieved, and they are symptom-free. So this is, I think, I did this slides a bit earlier. So as of now, first patient is 90 months, second patient is 7 months, and third patient is 6 months symptom-free actually. So we presented this particular case series in our APS, in APSR 2022 recently. Again, based on our center's experience, this case series shows the balloon bronchoplasty under conscious sedation is a feasible option, can be done successfully under flexible bronchoscope under conscious sedation, and shown an ability to maintain the airway patency for a prolonged period. It will be crucial during the pandemic era where operation theatre and ICU beds are limited and be less invasive modality with a less risk of complications for patients. Again, we're not sure when there's be another pandemic or another outbreak. But again, by mastering this particular technique, I'm sure we can give the easiest care to our endobronchial tuberculosis patients actually. So what is the maximum dilatation can be done for a patient? If you notice, this particular paper from China say that if let's say maximum 4 dilatation, the results sort of like static. We have achieved around 81% actually. So we try to focus maximum 4 dilatation, and after 4 dilatation, the results almost become a static 81, 88, not much of difference. But if you notice 1 to 2 around 36, 56, and 71%. So we try to maintain 4 times dilatation here. And this is something novel. Like again, we have tried something new in our setting. So whether we can use a cryo tools in our TB stenosis or not. So again, I got a referral from our ENT colleague, post-tuberculosis subglottic stenosis with critical narrowing of trachea around 5 mm, and the stenosis located 1.7 centimeter from the vocal cord. The length of affected segment was approximately 2 centimeter. So again, you may ask me why I choose cryo. So this patient has a history of recurrent subglottic stenosis. So before they refer me, at least they would have gone and dilated easily around 3 to 4 times prior to it, and patient had easily had a recurrence after a few months. So when I tried to devise the right strategy. Then I was thinking of, rather than using a usual method of using APC and cut electrosurgical knife and everything, why can't we use the cryo? Again, this is the first case in, I think, our region, as far as I know, that we are in the midst of publishing it actually. So based on our analysis, we tried to go with cryoablated stenosis. Subsequently, we did the CRE balloon dilatation and dilatation done via rigid bronchoscope. And we were able to achieve a luminal patency of 11 mm. So if you notice, as I mentioned earlier, tracheal diameter around 15 to 20 mm. So when you achieve 11 mm, she's a female. So we estimate the maximum diameter is going to be around 12 to 16 mm. So when you achieve 11 mm, you're practically achieving almost 80% of the diameter. So patient was extubated immediately after the procedure and she started walking around in the ward. And this is where if you notice, patient was intubated with MLT microlaryngoscope tube actually, which is 5 mm. So if you notice, she have only 5 mm potential space in trachea and risk of very dense tissue. And this was our cryo tool here. So we managed to dilate it on the same day. And if you notice, this is my rigid bronchoscope. We are dilating with a rigid bronchoscope now. So if you notice, this is 6 weeks after our cryo intervention for this particular patient. Beautifully dilated. There's no narrowing here, and this is a subglottic area. Can you see that? It's like, it's quite, remarkably open up. So when I did further research, if you notice, there's only one paper I could find, long-term results of bronchoscopic cryotherapy for post-intubation tracheal stenosis. This particular paper say that advantage of using cryoablation instead of electrosurgical knife, able to avoid the risk of airway perforation and minimal scarring and less chances of airway stenosis recurrence. But in this particular paper, they did use the electrosurgical method, like APC as well. So again, our case are purely cryo alone, and we need to have more data before we prove our theory that cryo going to be the useful for subglottic stenosis or not. So again, how about stenting? So if you notice, many people prefer to insert silicone stents for non-malignant cases. So this is one of the paper from Korea. Silicone stents were required in almost 94% of cases to maintain the airway patency, and usually after airway stabilization, stents were removed successfully in 65% of patients at normally around 14 months of post-insertion. So they insert the stent, they wait for almost 1 year. If patient is stable, and they try to remove the stent actually. But again, there's complication of when stent insertion is including excessive bleeding, pneumothorax, pneumomediastinum, stent-related complications like migration, granuloma formation, and mucostasis. So all this, when we consider, that's the reason in Alostar we are trying to move away from the stent insertion for the main bronchus stenosis to a purely flexible dilatation alone under conscious sedation. So whether we can use self-expandable metallic stent or not, it's a controversial, but again, this particular paper say that 85 SEMS was successfully placed in 77 patients. So long-term, almost 163 months follow-up, 48 patients did not develop raised stenosis, it's almost 62.3%. 29 patients developed raised stenosis, and eventually 12% remain under interventional therapies, and 11 had a bronchial atresia as well. So if you notice, in certain patients, we can even insert a self-expandable metallic stent. And if you notice now, recently there's a biodegradable airway stents available as well. So we are not sure how the outcome going to be in our patients. So again, I think the cost is definitely plays a bigger role. Any silicone stents cost nothing less than 2,000, 3,000, or 4,000. Metallic stents going to cost around 4,000 to 5,000, and biodegradable stents, is not mistaken, more than 5,000 per patient. So, and if you notice, these patients sometimes won't be able to afford these particular stents. So in conclusion, balloon bronchoplasty for bronchial stenosis is feasible under proper training and setting, and obviously it's worth exploring newer gadgets and techniques like how we have explored the cryotherapy in our patients. So with that, I would like to end my topic, and this is my medical officers team. This is our interventional team, and this is our official Facebook, just Alostar. With that, I would like to say thanks to Dr. Amin and his team. Thank you very much. Allow me to stop sharing my slide.
Yeah, thank you, Dr. Abin, for the lovely presentation on time.
Okay, on time. Okay, good.
So, can we have question from the audience? Do you have question from the audience? So far, no. Maybe I can start the ball rolling.
Sure.
Dr. Arvin, if I encounter a patient who is smear-positive TB, at the same time, the chest X-ray show segmental collapse or lobar collapse.
Okay.
Because I already have the diagnosis of TB, the question now whether patient have endobronchial TB or not. Do I need to do bronchoscopy, or should I just start the anti-TB and just follow up with the chest X-ray?
So as I say, first of all, we have number one, I would say that first, do no harm. Second, we need to protect ourselves as well from the infection per se. So I would say the moment ARB is positive, go and start the treatment immediately. Then if let's say this, if you're worried of this particular patient having endobronchial tuberculosis, I would suggest, if no life-threatening symptoms like no segmental bronchi or whatever, we can go at a later date to go and examine the airway. So as I mentioned just now, normally I prefer to wait for 14 days or at least near convert first before we go and intervene. So again, many people do ask me, what is the predictor of endobronchial tuberculosis? Actually, when I go through literature, there's no proper scoring system per se, which patient going to develop the endobronchial tuberculosis. So some of the papers mentioned patients should have a severe cough, hemoptysis. In normal x-rays, you may need to suspect endobronchial tuberculosis, or sometimes some people even mention that advanced cavitary lesions may accompany with the endobronchial tuberculosis. But again, long-term symptom, long duration of symptoms with the x-ray changes, like abnormal x-ray changes with the segmental collapse or lung collapse, I would say that we need to start treatment, and same time we need to get a CT scan as well. Then finally we go and confirm with the bronchoscopic way of doing it. So usually, if you ask me, acutely patient present with a sputum ARB positive, I'll start the treatment immediately, try to get a CT scan at the same time, and after 14 days, we try to go and evaluate. Unless patient having a severe stridor or whatever, we can't wait actually.
Basically, if you have a very symptomatic patient, you want to intervene early. Other patient you want to give
at least 14. I would say 14 days. I think because
adequate anti-TB, hopefully it will convert the sputum.
Yes.
And maybe later on we do bronchoscopy assessment after a CT scan done.
Yes.
In your experience, okay, we have one question. Thank you for the great presentation. What is your opinion?
Okay, mitomycin.
Mitomycin.
Okay, yes. I think many centers have used mitomycin as previously for the any tracheal stenosis or airway stenosis, especially when a post-intubation tracheal stenosis. But again, when I started my practice here in Alostar, we discussed among our ENT colleagues. Actually, if you notice, ENT colleagues are moving away from mitomycin technically. So because of some of the neoplasm, risk of neoplasm by using a mitomycin C, and mitomycin C, when you're using it, you have to be under proper precaution, and we have to make sure that no staff pregnant, and you must be carried with a special packaging and everything. But again, we have mitomycin under our interventional, within our interventional drug list actually. But for these particular patients, all three patients, I didn't use any mitomycin C, and happened to be like by giving around IV hydrochloride as well as the tap prednisolone, we managed to sustain the effect of the restenosis, and the airway is being patent. So I'm not sure what is the mechanism behind this, but again, so far for all these three patients, we didn't use any of mitomycin C. Even the last patient, remember the subglottic stenosis also, we didn't use the mitomycin C at all. So we open up with the cryo, and we ablate all the edges with the cryo so that it's beautifully open up. So I'm not very sure whether mitomycin C is really indicated If you notice, even many literatures having a controversial, how to say, arguments. Some are pro for mitomycin C, some are against mitomycin C. Some people are prefer to use a triamcinolone injection infiltrated around the stenosis. But again, if we are trained use mitomycin C, I would say please go ahead. If you are comfortable using steroids, please go ahead. I think I would say how you are being trained, that will determine the practice of your center actually.
Dr. Amin, another question. For the TB airway stenosis, does it normally occur during the diagnosis, during the treatment, or after the patient completed treatment?
Okay, actually it can occur at any point of time if you ask me. But again, what they said is if endobronchial tuberculosis, if it's actively cagitating subtype of fibrostenotic subtype, eventually 2/3 of it will go into the stenosis in future. So that's what I say, that early bronchoscopic may have some advantage over it. But again, as I mentioned earlier, if you notice, we are heavily dependent on a sputum AFB per se for diagnosis. So we may miss our endobronchial tuberculosis in early setting. But prolonged symptom, persistent chest X-ray changes despite adequate treatment, if let's say unilateral wheezing or stridor, please bear in mind that we are looking beyond normal conventional tuberculosis or pulmonary tuberculosis. We have to work out for our complications or endobronchial tuberculosis involvement.
Maybe one of the differential diagnoses that we have to entertain, especially patients who have worsening chest X-ray and symptom despite adequate anti-TB, sensitive TB.
Yes.
One of the differential would be endobronchial
tuberculosis. Yes, exactly.
Okay. Any other question? No question from the audience yet. Thank you, Dr. Amin. Can you share the slide later on with us?
Sure, no problem. Okay.
Okay, thank you, Dr. Amin. I'm going to give time for the next speaker to prepare. In between, I'm going to share the QR code for today's event.
Okay, thank you, Amin.
Okay, thank you, Dr. Amin.
Okay.
Please scan your QR code. I'm going to project this QR code end of each presentation. You get 2 points for the today's webinar. Dr. Taufiq, are you ready? Maybe we can start your presentation a bit earlier.
Okay.
Okay, Dr. Taufiq. Okay, so Dr. Taufiq is a respiratory fellow based in Queen Elizabeth Hospital, Kota Kinabalu. He's going to do 1 year attachment in Johannesburg, South Africa, going to be our national expert for TB in the future. Dr. Taufiq, the floor is yours.
Okay. Assalamualaikum. Thank you, Amin, and also all these committee member of UiTM for inviting me for this topic. So today we're going to talk about pneumothorax and also bronchial-pleural fistula, especially in TB. What is the intervention that can be done for it? So the content today will be basically we'll talk about management of pneumothorax and TB, management of bronchopleural fistula and TB, and all these challenge and consideration that we should always keep in our mind before decide on intervention in management of these two conditions in TB. So a bit on introduction, we talk about pneumothorax first. Pneumothorax basically describe as simple as an air inside the pleural space that is characterized by spontaneous, we can call it spontaneous in the absence of trauma or in the absence of any causative medical intervention. So if there is any medical intervention and it causes pneumothorax, basically we can label it as iatrogenic. So, and the spontaneous pneumothorax itself, we can further divide into primary spontaneous pneumothorax, where we assume there is absence of suspected lung disease. So another type is secondary pneumothorax, when it's occur in a patient with established underlying lung disease that we already diagnosed. So PTB, pneumothorax secondary to PTB is an example, a clear-cut example of secondary spontaneous pneumothorax. So actually, the prevalence or the incidence of pneumothorax in PTB is not that uncommon. So I'm quite surprised. The more TB patient you see, and you will see all these pneumothorax complication. I'm quite surprised. The whole, I mean, 5 years in, 5 to 7 years in Alostar, Respi Alostar, I barely see patient TB presented with pneumothorax, but surprisingly in Sabah itself, they present the TB patient present with pneumothorax as a first presentation. So most of these TB patient that present with pneumothorax usually we consider as a severe TB based on the chest X-ray itself. So I think one of the co-founding factor to contribute to pneumothorax is actually a severe TB, and also most likely due to patient late presentation to get an early treatment for TB itself. So let's talk about pneumothorax itself, how it's occurs, so and why the difference between management of primary spontaneous pneumothorax differ from the secondary pneumothorax. Because in primary spontaneous pneumothorax, usually we assume the lung is normal. So you know, one of the spontaneously one of the alveoli is rupture and causing leak of air inside pleural cavity and also cause pneumothorax. So we assume that only minimal injury occur here, and also because the lung is a normal lung, it's very good and high chance of recovery, and the recovery process is quite fast. For secondary pneumothorax, we know that the underlying lung is abnormal lung, so maybe the pneumothorax occur as a result from ruptured bullae, from the diseased lung itself, or ruptured cavity, and usually the injury or the leakage is much more higher than primary spontaneous pneumothorax, and that's why we do expect some delay and also some high degree of air leaking, high flow of air leaking inside the pleural cavity. So a lot of theory postulated why the TB and pneumothorax occur. So some of them saying that maybe the tuberculous cavity rupture into this, especially the subpleural type of cavity rupture and cause air leak into the pleural space and cause the pneumothorax. Another one is probably the pleural itself, because we know that PTB commonly associated with pleural TB. Either it's a reactive effusion or it's due to pleural TB. So usually from the fluid investigation, we will know whether there is a pleural cavity infection by the TB itself or not. So infection of pleural cavity itself can cause pyo and subsequently pneumothorax. So another type of patient I noticed here in Sabah, some of them presented with pneumothorax during the maintenance phase itself. So actually there is a theory postulated that whenever you have a cavity and it's healed by fibrosis, so the pooling effect of fibrosis will cause the rupture cavity and subsequently pneumothorax. That's why bear in mind, pneumothorax always also can happen during the maintenance phase. And also, again, when you have a diseased lung secondary to this infection, so you will have a lot of blebs or bulla, and this abnormal thing in lung parenchyma will cause pneumothorax itself. So this is a real patient. I mean, this is the real patient that we saw almost every day, every referral. So on average in Sabah, the referral for PTB from the whole Sabah to respiratory department is about 40 cases per day for complicated cases. For non-complicated, they will manage themselves. But for complicated, usually they will refer to us for suggestion of treatment. So you can see this is the type of X-ray, this is the type of PTB that will have the high chances of developing pneumothorax along the treatment or during the healing process. So you can see a lot of small multiple cavity. The involvement is bilateral. Some of them very large cavity, and also you can see the X-ray almost involving more than 2/3 of the lungs. So whenever you have a cavity or bulle, parenchyma, so this pulling effect, the wall of that cavity and the wall of your alveoli has become abnormal and very fragile and easy to rupture. So any changes in the pressure will lead to rupture of this cavity or and subsequently lead to pneumothorax. So the management of pneumothorax in PTB, it's not differ from the other type of pneumothorax. It's just part of another secondary pneumothorax. But a lot of issue being discussed on how to manage pneumothorax in PTB. Do we need needle aspiration, or the mainstay of the treatment is a chest tube insertion, or should we offer for conservative management, or can we offer ambulatory management, or even during the first presentation, can we offer chemical paralysis, or first presentation we offer thoracic surgery? This is always the dilemma that is faced by clinicians whenever they are dealing with patient with pneumothorax, especially secondary cause. So I think most of us aware about BTS guideline 2010 about the pleural disease and also pneumothorax. So I just want to, I think most of you are aware of this thing. So BTS also already released a new guide for pleural disease in June 2022. They make major changes, especially whenever you want to differentiate whether this is a first the primary or secondary pneumothorax. It does not really matter on you need the differentiation between primary and secondary pneumothorax. So whenever you have patient with pneumothorax, you need to ask, is the patient is symptomatic, regardless it is primary or secondary. You ask, you see the patient whether the patient is symptomatic or not. So, and you assess. If the patient is symptomatic, you assess high risk characteristic. So based on the study saying that all these high risk characteristic can give you a clue that this patient actually have a secondary pneumothorax, because most of the patient with secondary pneumothorax actually presented with you and presented to you for the first time, and they never assessed their own lung condition before. So that's why you need to ask yourself whether this patient is having tension pneumothorax or significant hypoxia, bilateral involvement, or do we know any underlying lung disease, or the age is more than 50 years if the patient is smoking. Let's say if patient is not symptomatic, we can opt for conservative management, regardless the size. So regardless the size, and also regardless whether it's primary or secondary pneumothorax. So let's say if the patient is symptomatic and they have a high risk, so low threshold for inserting chest drain. So meaning that you need to insert chest tube in this type of patient with this characteristic. When you have a high risk characteristic, you need to measure whether the pneumothorax is sufficient to intervene. So the cut-off point is actually 2 centimeters. Either you can count it from apex or you can count it from the hilar. So if it is more than 2 centimeters, it's actually safe to intervene and you can insert the chest tube immediately. If let's say it's less than 2 centimeter, they will prefer further imaging testing and reassess the feasibility of doing the chest drain under ultrasound or CT guided insertion. So let's say the patient don't have the characteristic, the high risk characteristic. You need to check whether the chest tube, the pneumothorax is safe to intervene again. If there is not safe to intervene, they prefer you to go for conservative management. If the pneumothorax is more than 2 centimeter, mean that it's safe to intervene, you need to ask the patient, what is the patient's main priority? So if the patient strongly refuses for procedures or procedure avoidance, you actually can offer them a conservative care, and you can look at that. If patient is actually primary spontaneous pneumothorax, you can discharge and also review regularly in 2 to 4 weeks. But remember, if you found out this is actually a secondary spontaneous pneumothorax, you need to admit the patient even though you opted for conservative care, because we know the degree of A-leak is unpredictable in the patient with secondary pneumothorax. So if our aim is to rapidly relieve the symptom or symptom relief, but the patient opted for ambulatory care, so you can offer ambulatory care. We will discuss about it later. And regular review outpatient 2 to 3 days, and we can remove it once the chest tube is resolved, once the pneumothorax is resolved, and we can review it subsequently during our follow-up. Let's say patient opted for short-term drainage. So you can offer first needle aspiration, and then if it is resolved, you can discharge. And if not resolved or not improving, you can offer patient for chest drain. So remember, in secondary pneumothorax, such as in TB patient, even though when you opted for conservative management, please ensure that patient is admitted and at least for 24 to 48 hours to review the condition. So whenever you have a very bad lung, especially a very severe TB or any cause of secondary pneumothorax, you always can consider pleural disease, even though it's a first presentation, especially when you suspect this patient will definitely develop severe pneumothorax in the future. So let's say the aim or the mainstay of treatment of pneumothorax, as we know for decades, is actually a chest tube or intercostal drainage. So most of the study showing that most of the recent study actually trying to compare the effectiveness, the complication, and the recurrence of pneumothorax. It's actually, they compare it with the standard measure, which is intercostal drainage of chest tube. So what is actually needle aspiration? Needle aspiration is a quite simple procedure. So usually it can be done at bedside. It's an aseptic procedure. You can just put a needle using a branula, standard branula. We prefer, usually what we use here is actually green branula, and then connect to a 3-way, and you aspirate it between 500 to 1,500. The previous guidelines say you can aspirate up to 2.5 liters, but the latest guideline said that most of the time patient only need 500 to 1,500 milliliter of air drainage. So it's either you achieve this amount or until you feel the resistance. So you need to stop at that time, and you measure how many mils already removed from the patient. So to compare needle aspiration with chest tube, actually we know that whenever you do needle aspiration, the biggest advantage is you have a shorter length of stay, and also the risk of overall complication almost the same. So there is actually no difference between rate of recurrence, either you do needle aspiration or intercostal drainage, and the need of further pleural procedure is actually reduced when compared to intercostal drainage. What is actually ambulatory management? I think now recently Western country are moving away towards hospitalization, and all of the all of the device are moving towards ambulatory management. So now we have ambulatory, outpatient antibiotic. We also prefer outpatient dots for even MDR patient. So we are moving away to hospitalization. So that's why you always need to ask about ambulatory option to patient. If patient keen for ambulatory option, the available method that that we are having here is actually the first one is actually Hamid valve. It comes with this small Hamid, the small tube with a valve. You just connect it with chest tube or chest drain that you insert. And also we always also have another one we call pneumostat valve. So the biggest advantage of pneumostat valve is it have a canister to collect effusion as well, because you know some of the patient is actually even though they have a pneumothorax, sometimes they have a small effusion. So this pneumostat valve can help to collect this effusion as well. So the advantage of Hamid valve basically is quite small, and also it's quite cheap. So most of the center are not having this device, so the patient need to buy themselves. So you need to ask the patient which one they prefer. But I do know some of the center also have this free pneumostat valve and also Hamid valve available in their center. So it's really differ, and it's really depend on your center itself. So the most important thing when you want to offer the ambulatory management, please ensure that you have the setting to monitor all these patients, because the biggest challenge for this ambulatory management, especially when my working experience in Sabah is actually patient living very far away from the hospital. So whenever something happens, you know, this is part of secondary management, and you cannot predict how much the volume of air leak that going to happen. So some of the patient actually have high air leak. So this pneumostat or Hamid valve cannot cope with this high volume air leak, and it will lead tension pneumothorax. And also, if the patient living very far away from hospital, especially in rural areas such as in Sabah, or Kelantan or Kedah itself, some of the center very difficult to reach the hospital, you should consider not offering this option to the patient. And also, we know that this chest tube, ambulatory chest tube, prone to dislodge, and you know the consequences of dislodged chest tube can lead to very devastating effect of the patient. So ambulatory management is actually same like chest tube, but we know that patient doesn't require stay quite long stay in hospital, and also you need to ensure that you offer this thing to a center that have good support and also available expertise. So we do offer this type of management for those patients who live nearby hospital within 5 to 10 kilometers. So some of the center, some of Western center do offer VATS or thoracic surgery for the first time pneumothorax. So usually what they will do, so basically VATS is actually 3 ports. I think later on our surgeon, Dr. Adli, will explain further probably regarding this procedure, but I've seen once VATS and also one thoracotomy last time when I did attachment in Sungai Petani, I think maybe 10 years ago. So basically from what I observe is actually a 3-port channel. To view, it seemed like what Respi do, fluoroscopy, but they have multiple port or multiple channel. So yes, we know that thoracic surgery reduce the recurrence of pneumothorax because you can do intervention immediately immediately, but the problem is the complication is slightly higher compared to you just simply insert the chest tube. So that's why you need to be careful, especially patient presented the first time of spontaneous pneumothorax. So another option is usually chemical pleurodesis for pneumothorax patient in PTB. So what we use is actually we use this 4 gram of tuck, sterile tuck. So depend on your center. Some of the center is actually sterilize the tuck themselves. They buy in bulk and measure weigh it 4 gram. And I think Alosta is doing that thing. They need a special tuck formulation, special size. So depend on your center. But what we are using now is actually this sterile tuck inside the bottle. Then what you do, you just dilute it. I think you can look on how to dilute it, and then just put inside our chest tube as a part procedure of tuck pleurodesis. They test a lot of other pleurodesis types such as bleomycin, but unfortunately, I mean the outcome, to be honest, prefer the tuck itself rather than other type of chemical pleurodesis. So we know the advantage of chemical pleurodesis is actually recurrence is lower, rates of recurrence are lower, but it's associated with side effects such as pain, and also rarely having a patient will have ARDS in this patient. So that's why you always need to weigh between the risk and benefit. But yeah, this is something that you can consider even though in the first time patient presented with pneumothorax in PTB patient, because you know it's a disease lung, provided you already rule out all the pleural infection. So if it's not a pleural TB, it's a pure pneumothorax secondary to underlying PTB, you can consider giving tuck during first presentation, especially in patient who are really I mean, you really have bad or severe chest severe type of TB from the chest X-ray. So another favorite thing, favorite for us to do for pneumothorax is actually conservative management. Actually, last time we were a bit worried to do this conservative management, but more and more evidence saying that actually it's not too bad to offer conservative management, especially when you have a good patient selection. Last time we were worried when patient admitted to casualty or ED presented with pneumothorax, but patient is totally asymptomatic. The size, the size is more than 2 centimeters. So whenever you counsel the patient to do chest tube or to do even aspiration, patient refuse to do it because patient is asymptomatic to begin with. So I think very difficult to convince them. So yes, in recent guidelines say that there is a role for conservative management, especially in patients who are asymptomatic. But again, I need to ensure, repeat it again, for primary spontaneous pneumothorax, yes, you can discharge the patient and see back, in 1 week time, provided patient is symptomatic. But in secondary, especially in TB patient, whenever they have a spontaneous pneumothorax, so always, even though you opted for conservative management, you need to review the patient inpatient. So we know that recurrence following spontaneous pneumothorax is about 39% after the first episode of secondary pneumothorax. So we always keep in our mind that surgical intervention might be needed after the second episode. So whenever patient develops second episode, you need to consider discussing with patient regarding the surgical intervention. So sometimes some of the patient, depending on the risk factor, you can always refer early to our cardiothoracic surgeon for elective surgery, especially those who are working in the very high risk areas such as diver and also pilot. So we know that this type of patient are at risk of developing the second pneumothorax. So we know that the importance of prevention of recurrence. So that's why this type of patient usually, after resolution of the first episode of pneumothorax, you can consider refer for elective surgery to cardiothoracic surgery. So let's talk about bronchopleural fistula and TB. So the bronchopleural fistula is actually basically means that sinus tract between the main stem, lobar or segmental bronchus into the pleural space. So in TB itself, most of the cases is occur in subacute form. So because this bronchopleural fistula usually occur as a result of post-operative complication, especially post-lung surgery, post-thoracotomy surgery complication, where the bronchial stump leakage and lead to air leak into the pleural space. So not much evidence on intervention on bronchopleural fistula specifically for infective cause or specifically for TB itself. So that's why there is a lack of consensus regarding what is the optimal management because of whatever treatment that they try to offer, because there's a small number of the patient cases, so the result is actually mixed. So you always need to suspect bronchopleural fistula when there is a persistent air leak. So whenever patient develop pneumothorax, PTB and pneumothorax, and subsequently patient unable to off the chest tube because the leak is persistent, I mean the continuous bubbling, or whenever you off the chest tube and there is a new increasing air fluid level or disappearance of pleural fluid from the chest radiograph. So again, a lot of paper describe how to manage bronchopleural fistula in PTB patient. Yeah, most of them agree on conservative management. Some of them prefer ambulatory management. Some of them say you can offer blood patch or chemical paralysis itself. And I think some of them also offer endobronchial, suggest to offer endobronchial intervention. I think this is the area which I mean Dr. Arvin can explain in detail about what is all the procedure available, and also yes, again, whenever you have bronchopleural fistula, the optimal management is actually referral to cardiothoracic surgeries. So let's talk about conservative management. Surprisingly, in bronchopleural fistula secondary to PTB, they prefer conservative management. So let's say you opted for conservative management. The literature recommend that you need a larger bore catheter or larger bore tube, at least 14 French and above, especially when you suspect very high volume air leak. You see the pleural is become infected or empyema, and if you plan for tub paralysis, and if patient ongoing mechanical ventilation, you know, whenever they have mechanical ventilation, first the inspiratory positive pressure can lead to persistent air leak. Some more, the pressure itself can cause more and more barotrauma and cause worsening of pneumothorax. So this type of patient, and also unstable patient, most of them need a larger chest tube. So the conservative management, a part of conservative management is actually treat the underlying TB condition, because we know that as the TB is healing and the fibrosis occur, so it will eventually close the fistula. And I can, from the literature, it's saying that almost more than 70% of the patient resolve by itself, and closure of fistula occur within intensive phase of treatment. So in ventilated patient, you always can consider putting the pressure, airway pressure, ventilator pressure below the critical opening of the fistula opening, so that whenever this flap is attached together, it will promote the fistula healing. And yet you need to still ensure, don't give it too low, the pressure too low, because you want to know adequate alveolar ventilation. So this is a biggest challenge. We know that in secondary pneumothorax, the alveolar or the lung, the pleural, visceral pleural rupture causing the pneumothorax. In order for the fistula to close, the flap need to attach together, and then eventually healing process can occur. So that's why the ventilation, if too high, then volume of air leak will be very high, and it prevent the flap to close. And yes, it will cause persistent fistula formation. So again, depend on patient preference. So some of the patient opted for ambulatory care rather than referral to cardiothoracic or surgical intervention. So if patient really prefer for ambulatory care, so we can offer Heimlich or pneumostat valve to this patient. You need to ensure the air leak is not a high volume air leak. So you test the patient, inpatient for few days, and then if the patient can tolerate this pneumostat and also Heimlich valve, you may discharge the patient and review back every 2 weeks to see whether the pneumothorax or the fistula closure, fistula heal, and the pneumothorax resolve. So, and also the most another controversial issue is actually application of suction when you have bronchopleural fistula. Do we need to apply suction? So there is a two school of thought again. They said, number one, don't apply the suction, because whenever you apply the suction, the volume of air leak from the fistula is increased, so it will open the flap and it will cause continuous air leak and subsequently delay in healing and closure of this fistula. So another school of thought saying that if the air leak is small, so the volume of air leak is very minimal, and the volume of suction is a high volume suction, you basically can immediately suck all the air inside the pleural cavity and leave the visceral and pleural fistula attached, and you just need to keep it for 24 to 48 hours, and eventually it will heal by itself, and the fistula will close. So it's really a mixed result on this issue. But let's say if you want to do suction, yes, first thing you need to consider whether this is a high air leak or not. High air leak, I mean, you can easily roughly say that high volume air leak, whenever the patient breathing itself, you can see continuous bubbling and it never stops. So some of the patient only will the chest tube will bubble only when the patient coughing or forced aspiration or forced coughing. So that's why that's a rough idea. So you want to measure the volume. Yes, there is a specific measurement, but I think roughly you can say from the patient clinical itself. Pleurosis, yes, you can consider pleurosis in prevention, especially for those patients who are not candidate for surgery, because we know most of the TB patient is actually malnourished, especially in Sabah. All of them having BMI, most of them who have severe TB having BMI less than 20. So it's not a very good candidate, and most of the patient, the important thing is the patient consent or patient approval for surgical intervention. So most of them are not keen, and some more in Sabah we have a problem with high number patient of unregistered people or unregistered resident here in Sabah. So that make us the option of thoracic surgery is very limited. So in this type of patient, maybe you can try pleurosis. So we have chemical pleurosis. You can offer the patient chemical pleurosis, especially whenever you see the pleura is actually attached together, and then you can introduce the lung is basically expanded, but the air leak is still persists. You can offer pleurosis in this type of patient. Another option is actually autologous blood pleurosis. The outcome is actually mixed, but it carry less side effect. Usually the effective volume is, they say that 1 to 2 ml of your blood, fresh blood, and then you instill inside the pleural cavity, same like you do tub pleurosis, and then you elevate the chest tube for few hours. So what this blood will do, this blood will enter all of this fistula and clot inside the fistula, and when they coagulate, so it will stop the air leak, especially the small air leak, and also again it will promote healing for this one. So always you can consider autologous blood pleurosis. So some of the literature say you can do up to 4 times if the first time is fail. So you can repeat the procedure because the side effect is very minimal, and you can do the procedure even though the lung is not expanded. So this is the advantage of autologous blood patch pleurosis. So thoracic surgery, I think later on Dr. Abdul will explain more on this thing. So basically we refer the cardiothoracic for closure of that fistula, but again the biggest challenge is actually to convince the patient whenever we discuss about morbidity, mortality. But I understand the recent technique of VATS, the introduction of VATS reduce the mortality and also morbidity, but bear in mind I mean, to convince them to go for operation is quite difficult, especially in rural area where I live, especially in rural area such as in Sabah itself. So again, that's showing superior advantage on length of stay and complication, pain and breathless compared to open thoracotomy. So but the rate of recurrence and also need for further treatment, VATS, the chance of need or rate of recurrence is actually higher in VATS compared to thoracotomy. So bronchoscopy procedure, this is another area that very interesting. So most of the literature saying that you need to differentiate between, is it a small air leak and also is it a big air leak. So big air leak they define as more than 8 millimeter, or some of them say that it's more than 5 millimeter. So depend on what is literature that you are doing, you are reading. So you can do, if it's a small air leak, you can offer occlusive materials such as Watanabe spigot or other material, I mean other chemical material in this patient, or more than 8 millimeter, they said we can offer stent, coil, or Emplatzer device. So basically Emplatzer device is the middle one. So Emplatzer device suitable for large air leak, where usually last time they used to close atrial septal defect or patent foramen ovale. So now they are using it to close the fistula or bronchopleural fistula. So this is Watanabe spigot. So you just can do you just occlude the area where the air leaks come from and seal this air leak, and subsequently I mean when there is no air leak, the lung expand and the other lung have to hyper expand, hyperinflated to expand the empty space. So this is example of valve. So you can place the valve inside the lung. So it acts as one-way valve. So the valve will go out. It will prevent the valve to go into the pleural cavity itself. So the biggest challenge is actually TB is infectious disease. So we know that any invasive procedure will carry high risk of transmission. That's why different center have different threshold to accept patient, but most of the center, I mean in Malaysia, last time when I worked in Al-Sultan also, cardiothoracic in Sungai Petani actually saying that probably the best time to do the procedure for TB patient is actually after the end of intensive phase, or at least you have approved that patient already sputum converted. So, but really differs from center to center. So we know that whenever the patient, we know that bronchial-pleural fistula will heal eventually over the time. So most of the patient actually after the intensive phase, the fistula will disappear and it will heal, and the lung is suspended, and patient actually does not require to go for any surgery. So and also we know that most of TB patients actually not fit, again, not fit for surgery. And the biggest challenge from bronchial-pleural fistula is actually really need a good CT imaging. So most of the CT imaging and most of the radiologists unable to identify or localize the specific subsegment that we need to occlude during bronchoscopy. So that's why bronchoscopy play an important role to aid the diagnosis. So I think some of them saying that using methylene blues and usually flushing the water, flushing the saline and see the continuous bubble. So bronchoscopy will aid the diagnosis on bronchial-pleural fistula. But again, go back to point number one, TB is very infectious. Need to be very careful, especially when you're working in the state in the center that have high burden or high incident or high prevalence of MDR TB especially. So if we don't want it to transmit to our healthcare worker, you don't want to caught by surprise that patient is actually have MDR TB. So what do I recommend, and what does most of the guideline recommend for procedure, especially airborne procedure like this? We recommend at least you have proof that this is not a drug-resistant TB if you want to intervene early. So I would prefer sending gene expert or sputum LPA to rule out all these drug-resistant TB before proceeding to bronchoscopy, even though patient already on anti-TB for more than 2 weeks or more than 1 month. So again, whatever intervention you do, don't forget your N95, because we have when the number of TB is high, eventually you will see a lot of healthcare worker also infected with TB. And I think we have XDR doctor in Sabah just complete treatment 2 years ago. Very devastating. I mean, during that time, luckily bedaquiline is available. I think 3 years ago, they underwent a lot of suffering, you know. So that's why I think don't forget your N95. Always wear your PPE, especially when you're dealing with airborne procedure, and also when you are dealing with long duration of surgery or long duration of procedure. So this is my reference. Thank you very much.
Okay, thank you, Dr. Taufiq, for the presentation. Do you have any question from the audience? Maybe one question for me, Dr. Taufiq. Is your intervention differ compare those who are still in intensive phase and those already on maintenance, or those already completed treatment? Does it influence your decision in terms of intervention?
Yes. To be honest, whenever patient we declare completed treatment, so either it's a treatment success or treatment completion, treatment completed, cured or success treatment. So this type of patient actually the risk of infective to other is actually similar to other patients. So I think this patient will benefit for full flex of all the procedure that available. So we know that the mainstay of treatment of bronchopleural fistula is actually thoracic surgery, either VATS or any. So those who are completed treatment, yes. Those who are in maintenance phase, also I think we can consider, but I will suggest we slightly put a high threshold on intensive phase lah, especially to do procedure, especially airborne procedure.
Okay, thank you, Dr. Taufiq. for the answer. We move on to the next speaker, and between that, I'm going to share the QR code again. Thanks again, Dr. Taufiq.
Thank you very much.
Okay, Prof. Faisal, are you ready? Then you can share your slide.
Yes, Dr. Amin. Thank you. So, Dr. Amin, can I start now?
Start now, Prof. Faisal.
Okay, Assalamualaikum and good evening. So first of all, thank you, Amin, for inviting me for this webinar. So actually, I gave a similar topic of management of pleural infection during the MABIC Congress recently. But however, this topic is a bit more controversial. Is using fibrinolysis in TB empyema per se. Okay, because why I say this is very controversial is because you know, when a lot of people, they have this thought that TB effusions or TB empyema, you do not need to give fibrinolysis. It will resolve by itself by giving anti-TB. But to be honest, you know, after practicing in respiratory for quite some time, you do see a lot of cases that comes back to you, you know, who develop an organized empyema or, you know, develop a fibrothorax and so on. So I still believe that, you know, we still need to intervene them early, especially when they have a TB empyema or pleural effusion. In fact, when you try to publish any papers in international journals, you know, a lot of times the reviewer will ask, you know, there's no indications of fibrinolysis in TB empyema, which I really disagree. Okay, I had the privilege of doing attachment in Australia under Prof. Gary Lee, and fortunate enough to receive Ministry of Health grant at the time, Ministry of Education, sorry. So I gained a lot of experience and knowledge learning under Prof. Gary Lee, and when I came back to Malaysia, we tried to improvise a bit of and to improve further on pleural management to tally with our clinical practice. So this is the outlines of my presentation. So I'll be talking mainly about the introduction of empyema and pleural infection and rationale of using intrapleural fibrinolysis. Okay, I'll be talking mainly on using tissue plasminogen activator and palmozyme in combination. What are the indications and contraindications of fibrinolysis? Safety of performing fibrinolysis and the dosing regimen. So a lot of people have different formulas and so on, including my practice. I have a different formula as well. And also the predictors of failure of fibrinolysis. And lastly, I will give a brief summary. So first of all, as an introduction, what is pleural infection? So sometimes we are a bit confused. There's people say simple parapneumonic effusions, complicated parapneumonic effusion and empyema, but at the end of the day, the treatment is almost similar. So we just label it as pleural infection to make it more easier. So this is actually a terminology to describe infection of the pleural cavity, which is caused by a parapneumonic effusion or empyema. So BTS guidelines have actually differentiated the difference between simple parapneumonic effusion, complicated parapneumonic effusion, and empyema. And it depends on the pH value, the LDH, as well as the color and the culture. So if you have patients with a pH of less than 7.2, LDH more than 1000, it is complicated parapneumonic effusion. But if it's turbid, then we know that this is actually empyema. All right, so these are the phases of a parapneumonic effusion. Initially, it will be exudative phase, then subsequently it turn out to be fibrinopurulent phase, and if it's left untreated or delay in you are less aggressive in treatment, it will actually transform into an organized phase. So when we give fibrinolytic agents, we can give at this stage fibrinopurulent phase. So once it becomes an organized phase, then there's no role of doing a fibrinolysis because it's so hard, the pleural cavity, the pleural thickening, and you need to refer surgeons at that time. So we try to prevent any infections from going into the organized phase. So empyema basically is a frank pus in the pleural space. So when you tap, you see a frank pus, there is empyema. But let's say it is serous in nature, but with the evidence of bacterial infection of the pleural fluid by gram-SNP positive culture, you still can label it as an empyema. So this is actually an example of ultrasound sonography done at bedside. So if I do encourage our young doctors, when you see a patient with a pleural effusion, straight away bring your portable ultrasound. Because if you see this kind of pattern, you know, when there is a hyperechoic effusion, that means you are not dealing with a simple effusion. You are dealing with something complicated parapneumonic effusion. And you see plankton sign like this, all right, you can straight away prepare a chest tube, yeah, because this is definitely an empyema, right? So as evidenced by this image over here. So I move on to treatment of pleural infection, and before that, start off with the a history. So this is actually Dr. Baron Guillaume Dupuytren. So he's famous for the nomenclature of Dupuytren's contracture. He is one of the greatest surgeons in his era, and in France at the time, and he was actually Napoleon's surgeon. So apparently Napoleon was suffering from hemorrhoid. And Dr. Baron, he himself actually developed an empyema, but he refused for drainage at the time. And what he mentioned to his colleagues was that he would rather die at the hands of God than hands of surgeon. And unfortunately, he actually died within 2 weeks because it was left untreated. So what I'm trying to say is that when you see a patient with an empyema pleural infection, you have to treat aggressively, and the mainstay of treatment is antibiotics, chest drain, plus minus adhesiolysis, whether you are doing a chemical adhesiolysis by giving intrapleural fibrinolysis or surgical adhesiolysis. So start off with the chemical adhesiolysis. So basically it's fibrinolytic. There are two main landmark paper, which is actually the MIS 1, okay, then MIS 2 paper, and now actually there is MIS 3. MIS 3 is still ongoing. So what is MIS 1? MIS 1 is actually comparing between intrapleural streptokinase versus placebo in the patients with pleural infection, and the conclusion was that there was no improvement of mortality, surgical rate, and length of hospital stay. And subsequently, when they did a MIS 2 paper by Rahman et al., it was published in New England Journal in 2011. There was actually 4 arms in the study groups, which is the altiplase alone, DNase alone, okay, combination of altiplase and DNase, as well as placebo. And they found that those in the combination group of altiplase and DNase therapy have improved in pleural fluid drainage. Also, there's a reduced in frequency of surgical referral, as well as length of hospital stay. And currently, it is still ongoing, which is the MIS 3 trial, which is actually comparing between early video-assisted thoracoscopic surgery versus early intrapleural enzyme therapy, and it is still in the recruitment phase. But for me, regardless of the outcome of MIS 3 trial, we must always actually offer your patient what do they want. They want surgical treatment or they want a medical treatment. If the patient comes to see me first, of course, I will actually provide them with medical treatment, which is fibrinolysis. But if you come to see a surgeon first, then probably they will actually proceed with a video-assisted thoracoscopic surgery. So what is the rationale of giving both altiplase as well as palmozyme? As you can see the picture over here, the CT scan, this is actually one of our real patient. This is a pigtail catheter being inserted, and you can see there's a lot of septations. So what you do is that the altiplase basically will break all these fibrils and making it into a single locule, and subsequently palmozyme will actually a cleanage of your DNase will make it actually less viscous, so that there will be a better drainage subsequently. And altiplase have a very short half-life, about 4 to 6 minutes, and it has a very low systemic absorption rate. So I'm not really worried about any bleeding complications because it is mainly absorbed in the pleura rather than absorbed in the systemic. And the dose of altiplase actually varies. But if you look at the Rahman et al. Paper, MIS 2 trial, they use a combination of 10 milligrams of altiplase with a 5 milligrams of palmozyme. And how does DNase comes about in the treatment of pleural infection? Initially, it was being used as an inhaled therapy in cystic fibrosis to reduce sputum viscosity. And they did some studies and they're using the same concept. It is also shown that the same nebules for DNA, when given into the pleura, it can also reduce the fluid viscosity and allowing for more pleural fluid drainage. So this is actually what in our formulation in UKM, I think in most centers in Malaysia, they have a formulation of 50 milligrams of altiplase. So you need to divide it and to give it at a different different interval. And DNase actually the idea of giving DNase in the pleural cavity was by Dr. Simpson et al. What he did was he built a simple device, and when he mixed actually streptokinase with DNase in a capsule containing pus, he found that those the container that actually contains combination of streptokinase and altiplase, streptokinase and DNase actually drains faster compared to the other agents. So there comes an idea of giving the combination therapy of altiplase and palmozyme. And this is how actually altiplase actually works. So first of all, the indications, right? Indications when to give altiplase DNase as well as altiplase therapy. So mainly when you see any patients with non-draining complex effusion, and you give a combination of altiplase and DNase. And contraindications for altiplase is actually not well established. Mainly is patients with high bleeding risk, although it is systemic absorption is considered to be very low, but you have to be very careful when your patient has a high tendency to get bleeding. And also if there's any pleural fistula, it's actually a contraindication, because once you give altiplase, patient can develop hemoptysis. So these are some of the examples of altiplase treatment in our center. So you can see that, this is initial patients with ultrasound that showing multi-septated, multi-loculated effusion. So after giving a single agent of, combination of altiplase and palmozyme, and this is actually the ultrasound a day after that shows that all these septations have been broken into a single locule. So this makes things easier for the drainage. So when we first started of altiplase, when I came back in 2016, so we start using a lot of altiplase in 2017. Prior to that, we were referring a lot of cases to our surgeon because we do not have any much options of medical treatment. So we recently actually published a paper, audits of all our patients undergoing altiplase monotherapy at that time because we do not have palmozyme in our center until 2018. So from 2017 onwards, so we did an audit. We compare treatment using intrapleural fibrinolytic therapy versus surgical intervention in complex pleural effusion, regardless whether this is pleural infection as well as malignancy. And what we found that intrapleural fibrinolysis was comparable to surgical intervention in terms of radiological outcome as well as length of hospital stay. And subsequently, I think in 2018 onwards, I managed to bring in palmozyme to our center using the special import permit, and we did our own research, and we published it in, again, BMC Pulmonary Medicine. So we did a combination of 16 milligrams of altiplase with 5 milligrams of palmozyme, and giving at a regular interval of 3 doses. And again, that it shows a significant improvement. So our success rate was at that time was 90%, and none of our patients had to be referred to surgical for any surgical failure of medical therapy. And why do we use 16 milligrams altiplase in our center? Because we know that MIS2 guidelines using 10 milligrams of altiplase. This is because at the moment there is no optimal regimen of intrapleural fibrinolysis, and we are using 16 milligrams because to suit our formulation. Our formulation comes in 50 milligrams of altiplase, and we know that once you have diluted all this altiplase, it can only be given up to 24 hours. So maximum is about 48 hours. So to utilize this, we use 16 milligrams at 3 doses, meaning to say that we use 16 milligrams 12 hourly. And usually we don't see any major complications of doing this regimen. But recently, there is a paper that was published called ADAPT-2 trial by Prof. Khairul and all. He used actually a very low dose of 2.5 milligrams of altiplase with palmozyme. And he found out that the conclusion of the study was that the starting dose of 2.5 milligrams of altiplase with 5 milligrams of DNase can be effective, and it can deserve further exploration. It depends mainly on the center and your formulation. If you do have a 10 milligrams of altiplase formulation, then you can actually use a lower dose. But unfortunately, in Malaysia, we do not have this lower dose of 10 milligrams unless you can bring into your formulary. So what about safety? A lot of people are worried about bleeding and so on. So when you look at the papers published internationally by Piccolo, Rahman, Majid, Mehta, Popovic et al., the rate of fatal bleed is 0%. Okay, rate of pleural bleed is only 3.2%, and rate of systemic bleed is 0.8%. That means it's very low, and you know that it is actually very safe to give intrapleural fibrinolysis. So we do see this kind of pattern after giving fibrinolysis. Initially, it will be serous, but subsequently, after giving alteplase, there will be hemoserous. But you don't need to be worried as long as the patient is stable. So these are our two different patients with hemoserous effusion post intrapleural alteplase. So you must always review back the patients and check the hemoglobin and so on. Sometimes they can get a small capillary bleed after alteplase. But as long as there is no drop of hemoglobin, and it should be okay. And most of the time, the bleed will actually resolve spontaneously. Hardly that you need to. So far, I've never had to refer any patients for interventional radiologist management for any pleural bleed. So other common adverse effects is actually pain, especially after the first dose. So most of my patients, before I give them intrapleural alteplase and palmozyme, I will give them analgesics 15 to 20 minutes prior to fibrinolysis, whether it's IM tramal or CAP tramal and so on. So we did publish some papers, case series and so on, apart from our previous research paper about using combination of alteplase and DNase and in the patients with high bleeding risk. Okay, that means patients who are very cachectic, patients who are on anticoagulation and so on, and all these are examples of the cases that we publish. So you can see that these are all case series, and this is actually the first patient that has a Klebsiella infection, thalassemia patient with very low hemoglobin, that has a very huge liver, all right, with liver abscess as well as pleural empyema. So successfully being treated with intrapleural fibrinolysis. You can see the X-ray, remarkable improvement. And another patient who's actually on anticoagulation. Patients have multiseptic effusion, but we do give alteplase with, and we do withhold the anticoagulation for 1 or 2 days prior to alteplase therapy. And subsequently, we can see that it resolved spontaneously. All right, and what about using in TB empyema? So if you look at MIS2 trial, they did not exclude TB in their study cohort. In fact, there were 3 TB patients who were placed in the placebo group. We know that 30 to 50% of tuberculosis effusion can result in a residual pleural thickening. That is why we need to intervene them early. There was actually a paper by Cow et al. That was published in 2015 that actually shows that intrapleural urokinase can also reduce pleural thickening. So this is actually one of the largest case series that we publish, looking at 7 cases of TB empyema and TB effusion that we treated them with alteplase and DNase. And you can see that, you know, all these patients have very septated and very loculated effusion. So we actually give this combination of 16 milligrams alteplase as well as 5 milligram palmozyme, and it results in a almost, you can see that the X-ray is remarkable improvement. This is post completion of fibrinolytic agent. This is actually 1 month on follow-up. Another 4 patients, again with tuberculosis effusion, or very septated effusion and so on, again with a remarkable improvement of the radiological outcome after fibrinolysis. So we can use alteplase and palmozyme in patients with TB empyema as well as TB effusion. So the paper that I showed earlier, the one that we use a modified regimen of intrapleural alteplase and palmozyme that we published in BMC Pulmonary Medicine. In this cohort of patients, we had actually 8 patients who had a tuberculosis effusion. And one thing about fibrinolysis, a lot of people think that this is actually a wonder drug, but we know that if you see this kind of patient with a very organized stage of empyema, you can see there's hardly anything moving, there's no fibrin at all. So please don't waste money and waste time giving fibrinolysis because it won't work. So this kind of patients is already too late, and you need to refer them to surgeon for decortication and so on. And of course, I have to emphasize that there are some indication of failure of fibrinolysis. So this is actually a paper by Kema Suwan as well as Abu Daf et al. And one of the indications that indicator that you might fail fibrinolysis is when you have a pleural thickening of more than 2 mm on CT scan. Actually, this is only a guide. I do have patients that have more than 2 mm thickening, but they are not in organized phase. I still give them intrapleural fibrinolysis and they do well as well. So basically, this is my last slide. Intrapleural altiplate and palmozyme should be used in patients with complex effusion, as well as empyema and parapneumonic effusion. And it is very easy to administer intrapleural altiplate and palmozyme. Previously, when I first came back, I had to administer it myself, but now I can leave it to my MOs. They are very independent in performing intrapleural fibrinolysis. We do have attachment MOs as well from Selayang that comes to our respi unit, and they also can do intrapleural fibrinolysis. And another common thing is that a lot of people have this opinion, old school of thought, that when you see an empyema, you have to put a large bore catheter, a big chest tube, which I disagree. We have a lot of papers nowadays that you can even put a pigtail to drain all this septation and so on, as long as you have a fibrinolysis available. Then you can actually give fibrinolysis through your small bore catheter. And the lowest effective dose for combinations of altiplate and palmozyme, based on international studies, based on the paper done by Gary Lee et al., that is called the ADAPT-2 trial, is actually 2.5 milligrams of altiplate in combinations with the 5 milligrams of palmozyme. But bear in mind that there are some case reports that using a very low dose of 1 milligram altiplate with 5 milligram DNase in patients with thrombocytopenia. And in my experience, we had one patient with a platelet of 10, that hematology patients that we developed a pleural infection. We actually started off by giving 1 milligram of altiplate and 5 milligrams of DNase, and slowly up titrate the dose. And we did not find any adverse effects by giving that dosage of altiplate. And TPA is actually saved with a very minimal risk. And hemoserous effusion post TPA is actually very common. And I would say that intrapleural TPA and palmozyme is actually an alternative to surgical therapy. And please bear in mind that if you have this combination of altiplate and palmozyme, you need to come up with your own protocol, and whether you want to use it 2.5 milligrams and so on. So it must be tailored according to your formulary. And the ranges of doses that can be used for altiplate is from 2.5 milligrams up to 60 milligrams per installation. Okay, if an empyema does not rupture, that will occur. That's by Hippocrates. Okay, thank you very much, and thank you for the invitation.
Okay, thanks, Prof. Faisal, for the lovely presentation. In fact, you share a few of your case report and case series.
Yeah.
It's good that we have our own local data. We have one question from the audience, keeping in the MIS 1 trial in mind. What about centers who does not have access to altiplate and DNase? Is it okay to use streptokinase?
Okay, thank you. I think this is something that a lot of people have been asking. All right. Of course, the international guidelines, they say that streptokinase has no effect in terms of mortality and rate of surgical intervention. But I do understand that in district hospital, we are still using streptokinase. To me, actually go ahead. If you do not have any other options of altiplate and palmozyme, go ahead. But you have to bear in mind that there are disadvantages of giving intrapleural streptokinase. Number one is that we have a paper that we published that shows that even with intrapleural administration of streptokinase, there is a tendency to develop antibody against the streptokinase. So, for example, if you have antibody that develops, the subsequent dose of streptokinase may not be effective. So, if you have an MI, for example, if you do not have any other option, so you can't give streptokinase anymore. You know that it won't work. The second thing is that the dilution of streptokinase, based on MIS 1 paper, they used 250,000 unit BD for 3 days. And we know that our formulation comes in about 1.5 million per vial. And sometimes to dilute that is a bit tricky. Okay. But there is no paper that shows what is the lowest effective dose to use streptokinase. And we know that altiplate, we can use as low as 1 milligram, as low as 2.5 milligrams. But if you do have a patient that comes to you with the high bleeding risk and you still need to give streptokinase, you're not sure what's the dose to use streptokinase. Yeah, so that's another problems with giving streptokinase. But the other options that you can do for pleural infection is actually pleural irrigation. So this is actually something that has been done in the past. It's being published by Hooper et al. So they use a pleural irrigation of 250 mils TDS. They just run 250 mils of saline run by gravity into the chest tube, all right, and let it outflow. So it actually found out it is actually an alternative to fibrinolysis in a center that do not have any alteplase or parmesan. Yeah, so I think it's not wrong to use streptokinase. Go ahead. It's better to give something rather than nothing to patient. And recently, I think there was a paper that being published that they use a lot of a series of 20 patients with TB and Empyema, where they published they use intrapleural streptokinase, and I'm not sure whether with DNase or combination with DNase, but they found that there is a positive outcome in those patients.
Prof. Faisal, when do you think the parmesan will be available in our national formulary?
When? Oh, that's very difficult because first of all, it is off-label use. In fact, when I first wanted to bring in, the pharmacy asking me a lot of questions. They said that this is Nebule form, why you want to use it, and so on. And you have to show them some paper that it is effective. In fact, in Australia and so on also, I think they just got US FDA approval. I'm not sure, but to bring that in Malaysia, I'm really not sure, because under Ministry of Education is quite easy. We do not need to go through what they call Ministry of Health. But if you are working in KKM hospital, you need to go through Ministry of Health. So maybe there are a lot more barriers to get parmesan.
If we encounter suitable patient, should we refer to you?
Definitely, I'm more than happy, but there is a cost for the treatment. The patients need to be aware of. So in our hospital, actually, alteplase we subsidize, so patients only pay 500 ringgit rather than pay the whole ampule of 2,000. But in parmesan, they have to pay additional of 700 ringgit. So altogether, it's about 1,200. But sometimes you have to be a bit creative. So what I do is sometimes I collect patients. So the alteplase we have extra. Instead of discarding it, I use it for other patients. And sometimes parmesan, this patient does not need all 6 doses of parmesan. There will be additional two ampules, and so I will use it for other patients who are very poor, poor. But this is off-label. It's only
50 milligram can use for 50 patients.
50 milligrams if you use 1 milligram, of course, yeah. But if I use 16 milligrams of alteplase, sometimes 1 dose is enough. So I do have extra another 20 milligrams and so on. I can use for other patients for that, as long as it's not being used more than 48 hours.
In terms of the dose, is there the maximum dose? You mentioned that you give 3 doses in 12 hours interval. Can you give extra dose if the collection is still there?
Yes, you can give. In fact, there is no maximum dose for alteplase. I hardly give beyond 50 milligrams, because by the time you reach 16 times 3, most of the time all the effusions actually will drain. But sometimes after giving 1 or 2 doses, you can see these locules will appear in another place, and you need to put another small bore catheter just to drain that. It might not be communicating between different locules, but as long as you break the majority of the septation.
Thank you. Excellent sharing session. Do you have any other question? No, from the chat section. Again, Prof. Faisal, thank you for the great presentation.
Thank you.
We end here. Maybe we can invite the next speaker. In between that, I'm going to share the QR code again. Thanks, Prof. Faisal. Mr. Ali, can
Can you
share
see
your slide?
my slide?
Sorry, Prof. Adli, yeah? Okay.
Can you see my slide?
Let me see that. Okay. Yes, Prof. Adli.
Yeah, thanks.
Prof. Adli is our cardiothoracic surgeon, recently promoted to associate professor. Congratulations, Prof. Adli. However, Prof. Adli going to leave us soon to go somewhere nicer. Okay, Prof. Adli, so the floor is yours.
Thank you, Amin. My talk going to be surgery in pulmonary tuberculosis. It's rather an overview because there's lots of detail in each approach and each condition that we have in pulmonary tuberculosis. So in history-wise, pulmonary TB is the history of thoracic surgery actually. The first thoracic surgical procedure was open drainage of TB pleural empyema was performed by Hippocrates. And during the first half of last century, the finding that Mycobacterium tuberculosis was an obligate aerobe lead to rapid growth of thoracic surgical operation. There were thoracoplasty, induced pneumothorax, plombage, and phrenic nerve crushing, part of the so-called history of thoracic surgery in pulmonary tuberculosis. It's not forgotten to mention Professor Jacob back in 1900 when he did and performed thoracoscopy as approach for pleural biopsy and electrolysis in TB patient. Of course, in history, back in 1944, the discovery of streptomycin modified the therapeutic protocol, and at that time, very little place for surgery. Developed in 1960s, rifampicin and other anti-TB drugs radically transformed prognosis of the disease. So this undermined the existence of thoracic surgery as a specialty. However, throughout the years, the rapid increase in incidence of lung cancer meant that thoracic surgeons soon found an important application for surgical and skill developed through years of TB surgical treatment. How about today? Nowadays, we are witnessing resurgence of the role of surgery in managing TB due to overall increase in global incidence, as we understand, the emergence of much drug resistant, either resistant to both isoniazid and rifampicin, the existence of drug-resistant TB like rifampicin, isoniazid, fluoroquinolone, and at least one of the injectable anti-TB drugs. So currently, the surgical indication in pulmonary TB, the first one is TB complication, for example, hemoptysis, empyema, cavity formation associated with aspergilloma, adenopathy with fistula, and if the cases display an inappropriate healing response to medication, for example, in clinical and we can observe in clinical and radiological pictures which remain unchanged or indicate progression, for example, in cavity and tuberculoma, in a condition where the acid-fast bacilli sputum smears positivity even after 3 months treatment period. So this we can see as circumscribed radiological lesion of the short line when you assess the patient, and also previous relapse in patient with histories of TB and proper drug regimen. You also can say that indication for surgery in TB can be divided as in complication, as mentioned just now, as a preventive surgery in aspergilloma, and also treatment-related complication like MDR. The issue in management of post-resection complication is still debated, especially in pulmonary TB. It features a wide range of procedure. We need to reinforce the bronchial stem in TB because we have issue with bronchopleural fistula. You need to sterilize the residual cavity and the issue of obliterate the residual cavity. Even we have to perform some sort like harvesting the pedicle-led docile or serratus anterior muscle, which transferred to affected site that can fill out the residual post-resection space. I'll just go through a few conditions in TB that we can offer we can offer surgery. For example, TB bronchiectasis, as we understand that among most common elementary lesion observed, up to 11% in TB patient. Mechanism is traction on bronchi due to fibrotic scarring and retraction within parenchyma, because it's chronic peripheral infection consecutive to bronchial obstruction, so you get fibrostenosis or bronchiolithiasis. And it can develop in 3 months after initial infection, common in female and left side because the anatomic features of left main bronchus. So in TB bronchiectasis, the surgical indication can be due to repeated hemoptysis, recurrent infection, or abscess formation. and resection should be complete and economical, what we call as a segmental resection. So of course, in this current era, VET is preferred because the technology, the skill, and the progress and development in VET is very rather rapid, and VET is always preferred in most of the thoracic surgery. And of course, success of surgery in TV bronchiectasis will be supported by if it's adequate preoperative preparation with aggressive physiotherapy, correct antibiotic plus sensitivity, and aim toward OT with a dry bronchial tree, which always the common problem and suffering things for the surgeon to manage if it is a wet bronchial tree, we call it. And apart from the surgery itself, the post-op complication can raise up to 20% because you have pleural adhesion and hypertrophic of bronchial vessel account. So we have sort of like perioperative bleeding intraoperatively, and then sputum retention is common. So you're complicated by atelectasis, pneumonia postoperatively. You get prolonged A-lead and bronchial-pleural fistula for the lead to residual space, later to be empyema. And also doing surgery with bronchiectasis, it can lead to fibrotic changes within remaining lung opposed to foul risk expansion. So at one point, we might to consider thoracoplasty. In view of long-term result in bronchiectasis, we offer them surgery. Up to 75% have symptom-free. It does significantly improve in 50%. However, logistic regression analysis show that history of TV and incomplete recession is the independent predictors of postoperative complication and failure to improve. So I think by all this, what we have in literature, it is important for us to select the patient properly so they will get the best surgical treatment if needed. Other is TB fibrostenosis. It's result from healing of endobronchial TB. It can be defined as microbiological or as the pathologic evidence of tuberculous infection of a tracheobronchial tree. Female predominance and mainly on left side. The two pathogenetic mechanism hypothesis is direct implantation of the disease into the bronchial mucosa and the compression by infected lymph nodes, which may ultimately ulcerate into the bronchial tree. Yet fibrostenosis result from circumferential retraction and submucosal fibrosis. People ask me why, as a surgeon, you need to know all of this, because this is important because surgically we have to understand the pathophysiology of the problem that you are dealing with, because it will decide what suture you want to give, how much you want to resect, and the possible outcome that we're going to expect from the patient that we intervene surgically. Of course, in patient with fibrostenosis, to offer them surgery, it has to be carefully planned. Because the main issue, you need to evaluate the underlying lung, either bronchoscopy or CT scan. How about the extensive bronchiectasis? For example, instruction is conservative procedure do not make sense, or resection of the disease lobe or lung is advisable. So those issues we need to really consider. And I believe that MDT that we always have in UiTem is a good platform for us to decide which patient that we need to bring into OT, which patient we can offer other interventional. Other than that, resection is a reasonable option when the stenosis involves a lobar or segmental bronchus, and the stenosis of the central airway with normal underlying lung or only mild bronchiectasis should be managed with parenchyma-saving bronchoplastic procedure. So possible operation include segmental resection, sleeve upper lobectomy or coronary reconstruction. All these are rather technical and rather anatomically surgical approach, which I won't go into detail. Other issue in TB is cavitation and aspergilloma. We understand that in TB, the saprophytic infection of a lung cavitation with Aspergillus species is development of a fungal ball, or in literature they call it megamycetoma. It's a typical long-term complication of TB. And the natural history of the disease starts with healing of cavitary tuberculosis and conversion of sputum. The next step is spontaneous detection of cavitation, progressive elimination of caseous necrosis, and lining with bronchial mucosa. Finally, aerosolized aspergillus may reach the cavitation through the bronchial tree. As a surgeon, we need to understand this because We have to decide the timing for surgery. Are we dealing with something active? Are we dealing something? We are talking about complication, post-TB treatment, and so on. Because there are a few papers suggesting to start antifungal. Some literature said no need. Some said 2 weeks, and so on. I think again we have to really assess the patient, the best option and treatment intervention that we can offer to the patient. Of course, in cavitation and aspergilloma, local hygrometry and temperature of 37 body temperature condition is most favorable for fungal growth and development of the megamycetoma. Mycetoma may increase cavitation size by secretion of proteolytic enzyme and progressive erosion of surrounding parenchyma. Sooner or later, the erosive process will ulcerate into blood vessel and cause hemoptysis. Other than that, in cavitation, aspergilloma is favored the apical area of the upper lobes. Since inflammatory process, we see a lot of systemic neurovascularization arising from intercostal arteries that make our surgery bloody, and a lot of abnormal blood vessel we're going to counter. And in all these patients, you also have some inflammatory reaction, which are significant with loss of weight or fatigue. So we deal with patient not just with cavitation and aspergilloma, but we have patient with preoperatively is malnourished and have a high risk to go major surgery. And of course, respiratory function may be altered by destructive process of previous tuberculosis or by previous surgical resection. That's why all these patients we have to really assess and evaluate the lung function and see how much we want to resect the lung part, and what is the expectation that we can observe post-operatively. And of course, majority, 80% of the patient we have seen can be asymptomatic, incidence denting from chest X-ray or follow-up from other imaging. So surgery in cavitation and aspergilloma is the most radical treatment is anatomic resection of the disease lobe. You are talking about upper lobectomy, because it eliminates both the mycetoma and underlying cavitation. Of course, as we mentioned, most frequent type of resection is lobectomy. The problem with segmentomy or which excision is that there is a risk of opening the cavitation and spilling content into pleural space. So there'll be lots of leak, and we're talking about a spillage of the content and dissemination of the content. Pneumonectomy carries an increased risk of post-operative septic complication, empyema up to 25% in excess. Any option apart from surgery, if unfit for anatomic resection, radical alternative is by direct approach of the cavitation with removal of the fungus ball and immediate thoracoplasty to collapse the cavitation. I will talk about the thoracoplasty later. In desperate ill patient, cavernostomy may be helpful, which is just open up and drain. Systemic antifungal are effective because we know that intracavitary injection do not guarantee a permanent cure. A relapse of aspergilloma is likely to occur if the cavitation is not obliterated or resected. Symptomatic patient should undergo surgery. In patient with cavitation and aspergilloma, postoperative outcome is improved in asymptomatic patient, even in those with complex aspergilloma and a previous history of tuberculosis. I think there's the parameters and criteria that we are happy to go in when patient is asymptomatic and good preoperatively profile. Overall complication rate of complex aspergilloma is slightly higher than that of a simple aspergilloma. Other condition in TB is distraught lung. This is a combination of different elementary lesion and also extensive tuberculosis, which may ultimately lead to a completely distraught lung. Lung seriously compromise long-term survival. It is well documented in literature. A recent survey of non-operated patients showed that overall mortality of such patients was up to 28%. The median survival was estimated at only 39 months. An extent of destruction located between 50 and 75% increased the risk of mortality in this group of patients with distraught line from TB. And we can see that it's a left predominance because we mentioned this again and again, the caliber of left main bronchus is considerably narrower. and this peribronchial space is limited by the aortic arch. Hence, the enlarged lymph nodes may determine compression of the bronchus with retention of secretion and chronic infection. I mean, surgically, we also have technically is rather more challenging to be on the left side at the hilar compared to the right side because of those anatomic structure. And Ashaw et al. Created the concept of left bronchial syndrome, which includes a significant left to right shunt owing to hypertrophy of the bronchial arteries, which we see all these big vessel which I encountered during this type of surgery cause lots of bleeding intraoperatively that we need to identify and make sure that we can control those sort of what you call neurovascularization. Surgery in TB distal line, any option, is if the presence of various complications such as ongoing pyogenic infection, hemoptysis, bronchopleural fistula, and relapsing tuberculosis, there is an indication to do so. In the case of bilateral disease, chronic respiratory failure may preclude any surgery. You can't do surgery on other side, but at the same time, the contralateral lung is very poor. With one lung, patient might not survive the surgery. And of course, it's challenging surgery to do in this kind of group of patient because you will encounter vascularized dead adhesion. There will be obliteration of pleural space, abnormal anatomy. You can't see plane, you can't see the real tissue. Everything seems not normal and will be bleeding, etc. The presence of granulomatous infection interferes with healing of the bronchial stump, and the active pleuropulmonary sepsis places the pneumonectomy space. So this kind of issue that we really need to consider and have to really assess in the patient and evaluate either this group of patient will get benefit from the surgery that we offer to them. This is other presentation that our respiratory clinic will talk to me and we discuss either this patient have what we call indication to go for surgical intervention, which is massive hemoptysis. Of course, it can become a life-threatening event when the flooding of the bronchial tree because it will compromise gas exchange. Acute blood loss itself will lead to circulatory collapse. And of course, in endemic area like our region, leading cause of massive hemoptysis include chief tuberculosis, also squealis of the disease. So this is our we call working diagnosis when the patient present to us the first time. And other potential causes of massive hemoptysis can be cavitary tuberculosis and also aspergilloma. So if you go through all the literature when we talk about definition of severe hemoptysis, the numbers of a definition, some say cumulative amount of bleeding at least 200 ml within 72 hours. Other literature saying about acute respiratory failure associated with severe hemoptysis. If there is need of intravenous constrictive agent and the need of blood transfusion. Of course, in this group of patients, the initial management is to stabilize and prevent asphyxiation. Intervention like in the bronchial manipulation can be offered, like local installation of cold line and vasopressor, placement of bronchial blocking balloon and use of rigid endoscope, and then other double lumen intubation to isolate the healthy lung. This one, when we do, we can stabilize the patient before we really go in and do a proper surgery. Double lumen intubation is one of the options that we can offer if we have a limited resource, for example, bronchoscopy. Following stabilization in massive hemoptysis, we can observe the patient. We can offer bronchial arterial embolization, and on my part is surgical resection. If we look back in our history, without further treatment of this hemoptysis, the risk of recurrent bleed close to 80%. With primary lung resection, gold standard of treatment was goose up in 1980s. However, lung resection was associated with a high mortality, high morbidity, especially when performed in active bleeding. You can imagine patient bleeding, they are hemodynamically unstable. We go in with so-called a major operation. That's why this contribute to the rate of mortality and morbidity during that time. However, in past 2 decades, embolization became the preferred treatment, especially in patients with tuberculosis. This is one of the recent article by the Turkish group talking about hemoptysis in the context of TB. What is the best management approach? In short, they mentioned that, of course, hemoptysis in TB is complex situation. The location and to locate the site of hemoptysis and defining the etiology may be difficult, especially in case of massive hemoptysis. It can be life-threatening, and the cause of primary tuberculosis. The careful assessment of the condition and quick management is very important, essential part of it. Deciding the management option among drugs, bronchoscopic procedure, interventional radiology, or resectional surgery is the highlight of the treatment in this paper. Maybe I can touch about the bronchial arterial embolization. This paper mentioned about may be a good method in controlling the hemoptysis, gaining time for planned surgery to control and stabilize the patient. However, in TB patient, the success rate of this method seems to be decreased, because probably due to the presence of bleeding also from pulmonary artery branch in this group of patients, and we know the pulmonary artery branch is not normal as a normal anatomy due to inflammation, as we discussed in aspergilloma and cavitary lesion just now. And in massive bleeding, emergency surgery become inevitable but carries high risk than a planned surgery, as we discussed just now. Surgical resection is still definitive treatment with acceptable rate of morbidity and mortality in selected patients, and only should be reserved for patients with adequate lung function. We can identify the exact site of bleeding and continue bleeding despite the adequate measure taken. Other condition in TB that we deal is empyema thoracic. I think we had a good discussion on that in fibrinolysis just now. But in surgical point of view, we understand that pleural TB will progress to tuberculosis empyema. This chronic active infection of the pleural space is characterized by thick ring of pleura. We can see from the CT scan. We call it cortex. The radiologist said thickened pleura. It can be dense and can be irregular calcification. Calcification is not a good sign for us. It shows it's hard. I had encountered a few cortex which is very hard. It's hard like the wall. We can't really, decode the pleura. When we decode the pleura, it take away the lung also. So you have a lot of air leak after that. And in empyema, the both parietal and visceral pleura usually surround a loculated pleural fluid, which we can drain surgically. It also contain a large number of tubercle bacilli. And as we learn in thoracic empyema, we know that thoracic empyema are classified into 3 progressive stages: exudative, fibrinopurulent, organizing. Of course, in organizing, the surgical intervention is most of the time the surgical indication and intervention is there. But in sedative, fibropurulent is at the borderline. But if you refer us this type of patient, suitable patient, the surgery will be easier. We can offer VATS and the outcome will be better compared to the normal medical intervention. When we talk about TB empyema, the surgical management is rather to do a pleural space drainage. Decortication is a form of treatment that we offer. So decortication will allow the expansion of the trapped lung. Either lobectomy or pneumonectomy, there will be another assessment that we really to decide preoperatively. Adjuvant and tuberculosis may be given. It may lead to the development of drug resistance. So it has to be really discussed with the respiratory physician, me as a surgeon, how we want to deal with this. Drugs are unable to cross the thick calcified pleural barrier. Another complication that we encounter and we have to be careful during the surgical intervention in TB empyema is bleeding, because you are dealing with inflammatory pathology, persistent air leak, because we have a frail lung tissue. At the same time, we do decortication, sort of peeling the cortex from the lung, or the peeling the visceral from the lung. So the air leak doesn't really seal. And the worst part, and the thing that we don't want to happen, but is most of the time is happen in TB patient, not straightforward bronchopleural fistula. So fistula, bronchopleural fistula, I think we discussed just now, but I want to talk about my surgical point of view. We understand its connection between bronchioles and pleural cavity. Both can happen in both active and passive form of MTB infection. A re-expansion of chronically collapsed lung requires surgical intervention. Of course, open window thoracostomy or elastoflap allows long-term drainage of pleural fluid and also creation of negative pressure within the thoracic cavity. This is a chest X-ray of one of my patients, which was referred from other hospital. This patient actually a prisoner, IVD, hepatitis B or C, I can't remember, was referred to me because of a persistent bronchopleural fistula. The chest tube they inserted almost 2 months, still bubbling, but patient, every culture being done, the TB actually was negative. So the team spoke to me, and I know at their point, after almost 2 months, they don't know what else to do. I said, okay, come to my side, and we try to offer surgical intervention. As Indian patient, what I did was we did a pleural drainage, and then I did a decortication, although the lung is not there that much, hoping that some decortication will expand the lung. Because I know the fistula is already there and it's difficult to be sealed. Then I offer what we call it bronchopleural fistula repair. And at the same time, I put latissimal dorsi flap, which is sort of like normal tissue to the pathological BPF, hoping that it will seal and granulate over the fistula. But yet, it never settled. As you can see that this is the second time I went in. After 2 weeks, the fistula is still there. We wait for almost a month. There was no rush. We are hoping that in case like this, because it's chronically affected, we're hoping that it's going to seal, but it didn't, and we went in again. At this second point, I did elastoflap, what we call open thoracostomy. You can see how the incision like. So it's basically an opening. I remove one segment of the ribs, make an opening so we can do dressing and allow the drainage from the respective cavity. So it never settled. So after observing and do dressing, and we don't see the outcome is not that good, but the fistula is really not granulate. The next step, I take the omentum, which was the surgery I combined with our general surgeon, Prof. Ramzi he took the omentum laparoscopically and bring it to the thoracic cavity, and I patched the omentum on top of the what you call that, on top of the fistula. But yet it's still there. It's not settling. If you can appreciate that the hole is still there. So although patient is very comfortable walking around, but you can see the iliac is there. So it never healed. It's never granulate. And at this point, we repeat back the TB, and the TB culture become positive. For all these 2-3 months, it was negative. And after all this while, that's might most likely contributed why this BPF never healed. So then we refer to respiratory, of course, start the anti-TB, and still is there. We go ahead because it's not closing. We went more aggressive. What we did was stenotomy, and we transect, or we isolate the left main bronchus. We isolate the left main bronchus intrapericardium, and we not transect, we stapler the left main bronchus. So basically, we keep the vessel, the pulmonary artery vein to the lung tissue, but we isolate the left main so there is no airway. So since that, there is no more fistula, it start to granulate. It's just a part of the surgery. And then you can see that start to granulate and the tissue going up. So it's really a very adventurous and long journey for me to treat this patient. I think it won't happen to all patients. This is the only patient I did this much of procedure to a patient. But I did learn a lot from him. The reason why I can do this, because maybe he's a prisoner, all cost is covered, and he's okay to undergo all the surgery. But I don't think any non-prisoner patient will endure this kind of procedure. For him, it's better to be in the hospital rather than to be prisoner. So every time I told him I need to do this, to do that, do anything doctor, I'm okay as long as tak masuk penjara. So that kind of thing, which I think again we have to be cautious, and we have to be what you call that, stand as a doctor, physician and surgeon looking the best for the patient. I believe what we did to the patient is correct, and eventually the BPF is sealed. Patient went home because the court case is settled. He's supposed to see me back after 1 month. He only saw me twice and he never turned back again. And then because we sent a letter to the PKK to the nearest hospital for the dressing, only twice they said it's already healed and the patient never turned up again. So apart from bronchopleural fistula, bronchoesophageal fistula is rather rare, encountered during active tuberculosis adenitis of mesenteric sequelae. Median age can be up to 56 years old. It can present with intractable cough worsening after swallowing fluids. Dysphagia that we thought they're going to have is very seldom. Investigation from bronchoscopy, a radio contrast study of the esophagus, for example, barium swallow, most of the time on the right side, up to 80% at the truncus intermedius. Treatment-wise, active tuberculosis adenitis, fistulization of the scissors lymph nodes into both esophagus and bronchus. So conservative management can be offered with stenting and tuberculosis chemotherapy, usually successful. Surgical-wise, it can be open removal of calcified nodes, resection of the fistulous tract, repair of both esophagus and bronchus, and the interposition of pericardial or muscular flap to spread both organs. It's rather a complicated, complex surgery, and we must ensure that patient is fit for that, because it's going to be long and lots of good tissue need to be there to cover the defect that we're going to handle. Of course, simple stapling is not recommended without division of the tract, because it is highly potential for spontaneous repermeation. Bronchiolithiasis is not well mentioned in our TB patient. I never seen one. I mean, we see in the CT scan and so on, but never been referred to me. But even referred to me, I'm not rushing to go for surgery. Bronchiolithiasis is a calcified or ossified material within the bronchial lumen. It can be progressive erosion bronchus by calcified medicinal nodes in relation to granulomatous infection or inflammation. Mild predominance in female, median age close up to 60 years old. And most common location is bronchus intermedius. Potential complication from this bronchiolithiasis can be obstructive pneumonia, subsequent bronchiectasis, and parenchymal destruction. Treatment-wise, it can be mobile broncholith, and a time of bronchoscopic removal should be made as a first intervention. Unless it's fixed, bronchiolith should be removed only in symptomatic patient and often require thoracotomy. Collapse therapy, have you seen one? Have I done one? I've done any. I haven't done any, but I know it will. My colleague from Pakistan, especially from Peshawar, which is the border with Afghanistan, thoracoplasty, they do more thoracoplasty more than appendicitis there in Peshawar, because they have lots of TB and lots of inflammatory disease that they encounter at that area. I know my colleague from India and Indonesia, this is the procedure they do, but I never done any. So what actually collapse therapy is a procedure before modern antituberculous chemotherapy. We're talking about early 1960s, which the only treatment of excavated pulmonary tuberculosis. The common principle is to collapse the excavated lung. So you collapse the space, and the external compression of the excavation joint to hypoventilation of the disease parenchyma. So allow for stabilization of the disease in many patients. And it is a permanent cure, because you don't give a space for the lung, there is no space for reinfection, and so on. That was the understanding. Other collapse therapy is intrapleural pneumothorax, plombage procedure, which I will say is very ancient. Thoracoplasty, as I mentioned, is still being done in a certain part of the world. Thank you. I'm happy to take any question. It's just an overview. It's good to have some discussion on this. Thank you, Amin.
So surgery in TB patient is not that straightforward, Mr. Adli.
It never straightforward. That's why when we have MDT, I will ask a lot of questions. I'm not saying that I try to avoid, but it's rather try to select the correct patient so we can have the best outcome from the patient. because
we have one
because
question from the audience.
Sure.
When is the best timing for surgical intervention? Is it 2 weeks after anti-TB or is it after completion of intensive phase?
This is very good question. It's being asked again and again, and I did ask the same question to my colleague which handled this in an area that really work on this. They said there is no specific time. If there is urgency, for example, abscess, sepsis, we have to go in. But of course, to go in early, we have to deal with the infective, the reason that why you don't want to go early. And secondly, the lung is very frail. So the result or the outcome from surgery is very, very limited. You might consider the stage disease, the first surgery, second surgery, and third surgery. Most of the time, if you ask me, you approach to me, I would say at least complete to 6 weeks. I'm happy if the patient or the pathology can be wait even until you complete the anti-TB. We are talking about 6-9 months, for example, trapped lung. If patient clinically is hemodynamically stable, no need of no need of respiratory, no need of any urgent intervention. We assess and we decide, because to go early in patient with TB, apart from infectious thing that we are worried of, is the quality of the lung. So sometimes when you deal and handle the lung, it just destroyed and you get A-leak non-stop. You thought you're doing well, but you will see that patient suffer, you yourself suffer emotionally because you're not doing just to the patient.
I think the other part of managing any TB patient is to address the nutrition, because for anti-TB to work, to prepare patient for surgery, we have to address the nutrition. Any special advice for us or tips how to boost the patient nutrition-wise for surgery?
Thanks, Hamid. That's a very good point that you mentioned, because of course in all these patients, the outcome muchly related to the nutrition of the patient, the operability of the patient. There's a few papers mentioned about the albumin level. They said more than 30, which sometimes all these patients will never hit 30 because they are malnourished. How much you put albumin because it's inflammatory, it keep leaking, effusion here, effusion there. But of course, you have to put a limit where you want to intervene. That's why stage procedure, for example, when patient sepsis, so you go in. What is the reason at that time? So maybe you just drain and you don't do nothing. The second stage, when patient stable, then you do decortication, and then patient stable. And next, you do a bronchial-pleural fistula repair. So you are talking about stage disease. I think it's important it's a dynamic management of the patient. We are looking at nutrition-wise, type of procedure that we are dealing, and we want to offer to the patient, and the end product that we expect from the patient. And of course, we understand that TB can be very hazardous until they have no lung at all. But we as a physician and being surgeon, we have to be, realistic. Either this patient can live with one lung. Is it enough for the patient, and so on? So we have to bear with it, because some of the patient, they can live with one lung. Some patient you need to intervene to expand the lung. And this assessment is very essential for us to do during the so-called dynamic follow-up for the patient.
So no more questions from the audience. I think that's end our session today. Thank you, Prof. Adli, for the excellent presentation.
Thank you.
I think that marks our end of webinar today. We finished early. I would like to thanks again all the speaker for the great presentation, and as well as the audience who stay till the end of the webinar. We're going to give you the link for the recorded video, as well as the slide from presenter. Dr. Adli, are you willing to share your slide?
Later lah, just let me know.
Later on. So we're going to give the recorded session and the PowerPoint slide to the presenter. Give us 2 weeks to do that. Okay, that is our end of our session today. Thank you very much for your attention. Thanks everyone, speaker and audience.